Good afternoon, everyone. I'm very pleased to welcome you all to this webinar. My name is Olga Kubasova, and I'm the founder and CEO of Image Analysis. Dr. Peter Strugal, consultant radiologist at the Royal Wolverhampton Hospital, UK, will be joining us to show how he uses Dynamica to quantify spondylar arthropathy MRI, using SI joint as an example. Then we will discuss how to use Dynamica's pixel-by-pixel algorithm to quantify inflammatory activity in MRI acquired from a patient with arthritis. Before we begin, let me give you a brief overview of Image Analysis. The company was founded in 2007 by me after I finished my PhD in computer science, working very closely with several institutions, including the Parker Institute, who were interested to understand if there is a better imaging modality for visualization of soft tissue inflammation than X-ray. The answer, of course, was MRI. With MRI, in particular dynamic contrast enhanced MRI, we were able to visualize in 3 dimensions soft tissue, such as synovitis or bone marrow edema. The next question was how to quantify this information so that the patients can be followed up and effect of treatment objectively measured. Our long-standing academic collaboration led to the development of commercial software, Dynamica, which incorporated a number of algorithms for quantification of static and dynamic MRI. Dynamica has been sold to a number of radiology and rheumatology departments in the first 2 years of the company existence, and we had over 40 clinical installations. While we started working with rheumatologists and radiologists specializing in rheumatoid arthritis, very soon we saw Dynamica used in oncology studies as well. However, we always felt that our users needed more support, especially with imaging data acquisition, setup of scanners, overall analysis of the results to identify patient subgroups, and distill information about the treatment effect. So Image Analysis team set to deliver a full service for an MRI-focused study, which included helping to set up right scanning sequences, developing imaging protocols, ensuring imaging data quality, and of course, in the center of it all was always quantification of MRI data. We now work with major biotech and pharmaceutical companies providing end-to-end service for MRI part of a clinical trial, as well as the investigators, researchers, and doctors who use Dynamica in clinical practice and R&D projects. For our researchers, we released a free version of Dynamica Open Access, to give you an opportunity to process up to 20 images. And this is a cloud-based solution which requires no installation and runs in real time. We plan to run at least 2 webinars per month, giving you an opportunity to learn about Dynamica functionality and, of course, try it in your work. All your feedback is more than welcome. Lastly, I would like to invite you to meet us at ACR in Boston and RSNA in Chicago, where we have a booth, and also presenting several abstracts where our investigators use Dynamica in their studies and trials. Let's begin this webinar. Welcome.
Normie, an imaging biomarker and segmentation tool for static MRI, by Mark Hinton, Chief Technology Officer, Image Analysis. I want to talk about using MRI in clinical trials where we only have static images. What we want from MRI in a clinical trial. We want the information we extract to be sensitive, that is to say sensitive to small changes in patient condition. We want it to be reproducible, that if we measure the same patient at different time points of the trial, if we measure 2 patients in different locations, we want to be able to get similar results for a similar level of disease. And we want it to be objective. Different observers looking at the images, we want them to get a similar score. But by the very nature, the MRI signals we measure and we display on screens in our software are in arbitrary units. The intensity numbers we have in those DICOM files varies from site to site, between scans, between patient visits, even just between patients. The same basic tissue will look different in the MRI images. This means really that if you've got unprocessed MRI data sets, it's very difficult to compare them. And the whole point of a clinical trial, of course, is that we want to take images from one day and compare them with images of the same patient from several months later and be able to make an objective, quantitative, sensitive, reproducible comparison to say, yes, the patient is improving, or no, the patient is not improving. So the solution to this, well, the solution is really is that we need to have a quantification technique for static MRI. And this we can do through a process of intensity normalization. And I will now explain what I mean by that and how we calculate it. So the idea, we call this concept norming, short for normalized intensity, is that we want to differentiate between different types of tissue based upon the signal intensity, but also based upon the relative signal intensities between the different types of tissue, because as we know, as we said before, the scaling is arbitrary. So here we're just looking at trying to differentiate between bone and cartilage, and we can see that we've calculated the map, and I'll show you how we calculate the map in a bit. It does pick up the cartilage. You can see it marked out. You can also see it marked out here, but this is now numbers which should be the same across any study, across any examination of a patient. So we can start to make direct quantitative comparisons now and get a score for the volume and signal intensity normalized of that cartilage. Also, by the way, this just gives us an improvement in the appearance of the image. So this is a color map overlay, and it helps us to identify features, in this instance, such as osteophytes and sclerosis. So what do we do to calculate norming? Norming is another one of these pixel by pixel calculations. What we do is we start by defining a baseline. Here it's a rectangular region of interest that I've defined. And we calculate the mean signal intensity inside that region of interest. We choose this region, the positioning of this region, to represent a reproducible area of tissue. So it would be healthy tissue, or it would be something which we expect to behave similarly across the duration of a trial and across a population. So here we've chosen inside the bone. And that mean signal intensity, SIM here, is the threshold against which we will calculate all the other pixels. So for each pixel, what we essentially do is we say, first of all, is it above the baseline or below? If it's below the baseline, we're not interested in it. If it's above the baseline, we calculate how much above the baseline it is as a fraction. So it's the signal intensity of the pixel minus the signal intensity of the baseline divided by the signal intensity of the baseline. So if it's twice as bright as the baseline, you'll get a value of 2. If it's the same brightness, sorry, if it's twice as bright, you get a value of 1. If it's the same brightness, you'll get a value of 0. And so if it's 10 times as bright, you get a value of 9, as it turns out. What we can then do for any region of interest, if I were to have had I drawn one here, for instance, is we can calculate what we call the sum normie, which is for every pixel for which we've got a normie value, we add up those values. And that gives us a measure which is partly dependent upon the volume of the ROI and partly dependent upon the signal intensity of the pixels within that ROI. So this normie measurement is starting to combine the effects of volume and increased signal intensity. So we're getting volume and severity, if you like. Just to illustrate the appearance of the normie map and how it can help sometimes. So here we have the original grayscale image, and now we've overlaid a normie map for all of the pixel values. And it depends upon your point of view, but this really just makes a bit of sclerosis here stand out more for me. And at a different orientation, these osteophytes are easily identified in the color map. So it's a useful illustrative tool, useful when you're illustrating conditions to people. What the normie process also allows us to do is have a good functionality for drawing regions of interest and segmenting parts of the image. So let me go through this. In number 1 over here, we have the original image and we've drawn our baseline in the bone. From that, we generate the normie map. Dynamica does all of this for you, of course, and we overlay it onto the image. And we can see, again, we see as before, we're starting to see the cartilage, but there's a whole lot of other stuff going on. Moving over to the right, this histogram is of the normie values in this map. So these pixels over here, which are very, very bright, are over here somewhere, and all of these not so bright ones are what's occupying this lower end of of the histogram. So what we can now do with Dynamica is we can just with our mouse click and drag and define a region of the histogram, and now the map over here is only showing the pixels with normie values in that range. So we haven't got the ones over here, so we lose some of this bright stuff, and we haven't got the ones down here, so we lose a lot of this darker stuff. And now we see we're being left with more and more of these pixels are actually now still in the cartilage, which is good. There's further functionality within Dynamica, the fitting of a ROI to the map that's being displayed. So now what I can do is I can draw a big and very rough ROI. I don't have to be very careful. I wouldn't have to be very careful about this at all. And Dynamica, at the click of a button, will shrink this onto the map. And you can see here, we've got these little bright flecks here, and they've now become little ROIs in their own right. But this whole region around here of cartilage has become a single ROI in its own right. So I now have quite a lot of ROIs. Within the functionality, I can choose the minimum size of a ROI that the software will shrink the big ROI onto. So I can not have these simply by setting that threshold to be about 20 or something like that in terms of pixels. And then where I've got things which I still don't want, I can just delete those from the ROI table. So very, very quickly, I go from having a very complicated, intricate cartilage shape to it being segmented. It's fantastic, and now the software will automatically calculate the numbers for this cartilage, the area of this one, if we can do it across several slices, the total volume of cartilage, and the normie value, the sum normie value, will give us an indication of the signal brightness, normalized signal brightness of that cartilage, which may well be an indication of the quality of the cartilage. Now, we can't be sure about that, but we're undertaking studies and looking to do trials at the moment to understand what the normie value in cartilage which is suffering from degradation really means. So that's a very exciting thing that we're looking forward to do, and we will keep you all posted on that and publish our results around that. So just a short presentation, and in conclusion then, so with normie and analysing static MRI data, we've got a great visual aid. It helps us to highlight specific signal intensities in the images that are related to specific disease indications. So we can tune it for any particular disease and anatomy combination so that normie will highlight for the observer the areas that look like disease. And that colour map that we overlay gives us an alternative to the grayscale appearance. It's a different contrast, if you like, and you can potentially see different effects, and I think it is a useful thing, particularly for explaining things to the layman, and particularly to non-radiologists. And we get an easy and fast ROI drawing for complex shapes, for intricate segmentation, very often where there aren't clear boundaries to the regions of interest, where the cartilage in the image fades into the other tissue, or in a spine where lesions fade into the rest of the vertebra. And out of this, we've got an imaging biomarker. It uses normalized image intensities. Through the definition of normal tissue, we can make comparisons across patients, and therefore we can compare statistics across patient exams, across patient cohorts. So we're developing now a very powerful tool to aid the quantification of static MRI in clinical trials and in clinical treatment pathways of following up a patient. Thank you very much.
So this is Peter Strohel, consultant radiologist. This is an analysis of the sacral MRI images. While the images are just being called up, I'll just very quickly introduce the process and say that it is fundamentally based upon a sacroiliac joint analysis derived from a method initially employed for isotope bone scans to work out the presence of sacroiliitis or to exclude it. And although based on a rather crude test, we are refining it for use with MRI. The first thing to establish is a region called baseline. So having identified an appropriate coronal image with abnormal marrow signal on it, on that same slice you need to identify a region of normal marrow signal Typically, the sacral promontory or central sacrum is taken, as this area is relatively unaffected by inflammatory spondyloarthropathy. So you select a suitable, simple region of interest, map it out over the image, and from that you can then derive a color map image against which to both visually judge and semi-quantitatively assess uptake and signal intensity elsewhere in the image. Essentially, you can then highlight all pixels which have intensities above your healthy tissue taken as baseline, and you can adjust exactly where that baseline image is and what those values represent as well. Having decided what the baseline is, you can then draw regions of interest around the sacroiliac joints. This can either be starting around what is perceived to be a normal joint or what is perceived to be abnormal signal in the first instance. It doesn't really matter which way you go, so long as all images are appropriately labeled. And perhaps in an ideal setting, you would even follow the same process for all images and for all patients. So if you always start with the left SI joint, you would always draw the left SI joint first. And you can, having drawn one region of interest, simply mirror the size of the region across to the contralateral sacroiliac joint. As you have a color map and a normal or background baseline reference point, the regions of interest over the abnormality or over the sacroiliac joints don't have to be too specific, because the software will allow for any discrepancies within the regions of interest. The software effectively uses the baseline to produce a surrogate imaging biomarker within each region of interest, focusing on the size and intensity of the voxels within it, and therefore providing information on the intensity of each voxel and any lesion within each region of interest. The sum positive is the sum of all the colored pixels within the region of interest, and the software can actually give you information about the size and the pixel intensity of those specific lesions. You can either do it for one individual slice, if there's one particular slice that stands out as showing abnormalities, or you can apply it across all of the slices in the sample data set. So in this instance, we are specifically looking at the coronal stir images through the sacrum, and it can be applied to all of those. It simply propagates the regions of interest drawn onto every single slice that you want to apply it to. So having decided whether you're going to apply it to a single slice or the whole stack or a subset of the stack, for the larger regions of interest, you can then also fine-tune the regions of interest within that. So you can draw regions of interest, much smaller ones, around specific foci of abnormal signal intensity that's obvious to the eye as well as obvious on the color map when you adjust for background. And you can check these by turning the color map on and off, or effectively phasing it in and out to check where you're drawing your regions of interest, the smaller ones. Here there is a need to be slightly more precise as you map these regions of interest, but you simply want to do a contour around all the abnormality in question. So in this instance, they're being drawn around the upper or superior aspects where there is particularly high marrow signal around the left sacroiliac joint, within the much larger region of interest around that joint. This then gives far more specific information about the voxels contained in those smaller regions of interest, and gives you more specific information about that, and again can be propagated to the other slices. The clinical significance of the larger regions of interest around the sacroiliac joints can be correlated, as I mentioned, to isotope bone scanning. So we have an understanding already that the peak values and average values within the joint-related regions of interest can have a definite clinical significance because you can highlight the abnormal joint. What's perhaps less obvious is how you can highlight how much of the marrow signal is actually abnormal, where the right SI joint looks remarkably normal. The left one, actually on the color map, looks more abnormal, and this holds true when you specifically look at the pixel intensity values within that larger region of interest, as well as looking at the color map. What we don't yet fully understand is the significance of the pixel values within the smaller regions of interest, localized to the foci of highest marrow signal intensity around the left SI joint. We don't know whether that's going to specifically correlate to disease, what information it's going to tell us about the disease process, how active it is or not, but there is a suspicion that we should be able to gauge disease response on follow-up images using these peak regions of interest.
You now had an opportunity to listen to Dr. Peter Strugel explaining how he uses static MRIs to quantify spondyloarthropathies. We would like to move to the next case, which is about dynamic contrast enhanced MRI. But before we proceed, let me just talk a little bit about why people would use dynamic contrast enhanced MRI. As you saw, a static image shows fantastic anatomy. However, it lacks functional information about inflammatory activity. We really can't treat synovitis, edema, or tumor as a lump. In fact, every single anatomy or pathology will have the function. So when we induce contrast, it actually attracts to vascular tissues. So in absorbed by vascular tissues, it shows us how perfused or how vascular those tissues are. This is in effect a functional information. So dynamic contrast enhanced MRI incorporates the ability to show very good anatomy as well as the function. Of course, if now I bring this into clinical trial settings or multi-center study, we are after automated processing. With a static MRI, all you could do is to look at a single image and do a report. And as you could see, we were trying to compute objective biomarkers, but still there is quite a lot of observer input. So that will, of course, not allow us to acquire completely objective results. We will now show you how to quantify dynamic contrast enhanced MRI in a completely automated manner, which of course takes out the observer bias. And that gives you objective and incredibly sensitive biomarkers. A second point, which is incredibly important, quantification of dynamic MRI needs to be continuous. So when you have a scoring systems which are based on 0, 1, 2, 3 values, telling you if there is a healthy joint, 0, 3 is the worst imaginable inflamed joint, you lose that sensitivity of the scoring. So with our quantification, which you will see in a minute, you will see that this is continuous scoring system. So in fact, we can quantify 5% of enhancement, 20% of effect of treatment, or anything in between. So that allows you to have not just objective, but very sensitive biomarkers. And of course, once we have objective and sensitive biomarkers, this increases the power of the study. And so effectively, you could use smaller number of patients to get exactly the same results. Well, now I let our speaker give his presentation and give you a case, but please, if you have any questions, email us, and we would be very happy to send you further papers and, of course, let you to try Dynamica in your own clinical practice or research. Thank you.
Hello, everybody, and welcome to this webinar where in the next 5 minutes we'll try to show you what we do with the dynamic data of, in this case, a wrist. After having uploaded the images, you can see on your left-hand side that you have the dynamic data and they are selected. You can unselect them by just clicking the bottom here. You know, here up here you see that the slice contains of 18, or the study contains of 18 slices with the 35 time series. And what I usually do, I upload the series, then I scroll through the case to ensure that I have all the interesting slices. I find more or less a middle slice where I can see some of the anatomy. And then I'll use the lower slider down here to see the time series. And as you can see, slowly scrolling through the series, there are some enhancements taking place. And I do that back and forth a little bit to get an idea of how severe the inflammation is in this patient, and also to ensure that we have in the beginning baseline frame without contrast in it. So you can see in the beginning, no contrast. When I go through the slides, 1, 2, 3, then contrast begins to come in, 5, and so forth. So this ensures me a little bit of the data control that I have all the different time series needed to do the curve and registration analysis. After that, I click next, and then we come to the patient motion correction window. And here, as you can see, wherever I put in the image, you'll see on your upper row here, you'll see the pixel values or the curves. And what I'm doing here, I'm trying to find a vessel. And especially I'm trying to find an early enhancing vessel, and usually this is the radial artery, as you can see here, with a typical artery signal, steep wash in and fast wash out. When I have that, I double click, and then you see the graph becomes yellow, and then I count 1, 2, 3 baseline, and then we begin to have enhancement after time series number 3. Then I choose the first slice after contrast begins to come in as the reference frame for doing movement correction. And since, well, what we do, you can also choose any other frames, but we have discovered that having a little bit of contrast in the images when you do the registration will ensure a very robust and reproducible registration. So in this case, we choose frame number 4. And then we say run. And you have the possibility here to see as it running out here on your left, you can show the progress. And it takes, for these 18 splices, 30 chances. It takes less than a minute to do all these corrections. So now it's finished, and another window comes up, and this window ensures that we have on the left-hand side the movement corrected frame, and on the right-hand side the movement corrected frame. As you can see, it has become a little bit more smooth because every frame in the time series have now been aligned in within the same voxels. And this will also enable you to see that some of the movement that happens in the periphery, especially around, if you notice here, around the thumb area, have actually disappeared. So now I'm happy with that. I have a red frame around the time series, which means that this is the one I want to work with onwards. And I then click next. So actually here I'll have the parametric map, and the parametric map has to be calculated in order to do the color coding as well as pixel value classification from the dynamic data. So I more or less always choose all frames as active as I see a severe movement within one of the frames, as you can see here. No severe movement. Baseline, there's a default of 1 and 2, but as you might remember, if we go through the time series, it's when you find a vessel, you see that 1, 2, 3 might give you a better baseline. And again, here you can see that having clicked on it, 1, 2, 3, and after 4 in the vein, it slowly begins to enhance. So we choose 1 to 3 as baseline. And then press calculate. And again here you can see it begins to run. And down here on the graph you'll be able to see that the green box represents the baseline. So whatever's within the green box is what we have chosen as a baseline. You can also force the calculations to be done with a minimum contrast enhancement onset. So if you want every calculations of steepness of the curve to be done according to a specific time point, you can put it in here. But see now, the parametric maps are ready to be displayed already now. It took less than 30 seconds. And now we should have here on your upper left corner, you should have this choice of parametric maps and statistical maps. And this is the parametric map with the gadolinium map. And we can apply that. And as you can see, there's a lot of contrast uptake in many of the tissues in this hand. You then also can apply the initial rate of enhancement map, and this is usually the map that I use to have an idea where the highest diffusion takes place, because with this map it's easy to define the vessels, which are tubular structures in the coronal plane, as this is, with a very bright colors, because you have some very high peaks and a high, and thus also a high initial rate of enhancement. The veins are a little bit less pronounced, but again, you can see it's feasible to go through all the different tissues and see how the curve responds to that. Another very good tool here is this bar, where you can actually dim the color coding, so you can see the grayscale down below. And I usually use a color coding like this, because then it gives me an idea of the very severely inflamed joint areas along with the more, let's say, relative, less enhancing muscle tissue, which probably is a normal physiological phenomenon. And then it's also easy to see the vessels. So in this case, we can easily see that just in this slice that we have a moderate volume of synovial enhancement in this joint, but with some very high hotspots in both the ulnar and radial part of the joint. And then we also have a severely affected MCP joint. But again, notice how different areas enhance very differently. This area, for instance, you can see down under the yellow bar, and compared to this area here, which is also within the same capsule, it has much less enhancement. You also notice on this image that you actually have enhancement in the hip joint, and especially it's here in the third and fourth hip joint. Sorry for that. Go on back. Here in the third hip joint, and again one back. Very high enhancements again, but not as high as in the yellow bar down here, which was in the very high enhancing area in the second MCP joint. So it's really easy to, with this tool, to actually analyze and get an idea of the various enhancement patterns in the area of interest to separate the vessels from the pathological enhancing tissues from the normal physiological enhancing tissues like muscle. And then I can actually go to the next step, and this is give me an idea of how the different maps of maximum enhancement in the middle, initial rate of enhancement, gadolinium maps, time of onset maps, time of washout maps, and initial rate of washout maps. And again, notice here how especially on the ME and maximum enhancement maps, as well as the IRE maps, you can see that the MCP2 third hip joint and also the ulnar part of the radial ulnar joint and radial carpal joint is highly enhancing. Also, both on the ME maximum enhancement and on the initial rate of enhancement maps. So these are the most severely affected, or in other terms, inflamed areas. It also corresponds quite well with you have a high initial rate washout. You have washout, as you can see on the red colors here in the gadolinium map. So all of these maps together can give you a much more dynamic idea of where the enhancement takes place, but also how it actually perfuses the area of interest, and thus enable you to separate highly affected from lesser affected areas of the disease. You can also, if you have a 3D volume set, you can go to the multiplanar reconstruction. As we don't have that, we skip immediately to the region of interest map. And with this tool, I can, as you can see up here, choose a polygon mode, and then by holding down the left mouse button, I can do a random ROI that will, in the end, give me the curve of interest. As you can see down here, the yellow graph. So that's the area of enhancing MCP joint. And if I can take a muscle as well, sorry, I have to click again to have the polygon mode, and then I do a muscle ROI. And as you can see here, if we go and give it another color like green, by clicking on the color bar, you can see that the MCP2 joint in this slice has a very steep wash-in and a high plateau, 2.5, something over the baseline, whereas the muscle ROI only go up to 1.3, and that's a very slow enhancing tissue, which probably is a normal physiological phenomenon. Again, you can look at other areas like the area down here where the ulnar inflammation takes place, and again here you can see that the new code, which you can give blue, actually enables you to compare areas of various intensities. You can also, by double clicking, get an idea of, down here, by double clicking you should be able to have actually where the cursor moves, and this is the white white curve. Down here you have all the statistics with the volume, the area of pixels. As you know, the matrix, you can calculate it into an area in the square millimeters. If you have multiple ROIs, for instance, if I go to the next slide, and then I will do another blue MCP joint circulation, then I can actually, both in this window, as you can see, giving a blue color again. I can take the two blue colors and I can put them into a blue as volume. And then if I come down here at the volume ROI, which you then can rename and, for instance, say volume density 2, and this is the curve from that, the mean curve from that volume. Another feature I would like to show you is this masked parametric maps, where, for instance, if you put on the IRE map, and then you can mask the parametric maps in all the other areas besides the one where you have the ROI, and then you can, by unclicking that button here, you can again see the full color coding that you can dim a little bit, which I like because the anatomy is better depicted. So this is just to give you a short instruction to how you can use the tool and to what you can get out of it. When you've drawn all the ROIs, the last thing you can do is to go to the report section, and you can create the report in either a PDF with the imaging examples, or as an Excel, or as a Word document that you can just copy paste into your presentations, your publications, or for the Excel files directly into your statistical program for further analysis. So I hope you got an idea of the versatility of the tool, as well as the many opportunities that the tool allows you to do with the data.